right. Hello, everyone. I'm Aubrey Rhodes, and I have the privilege of serving as LCRF's Executive Director. Here at the Lung Cancer Research Foundation, research is our North Star. And so we are focused on funding research that's really going to accelerate progress for people living with lung cancer. One of the ways that we continue to fund really great, innovative research is through our Free to Breathe Walk program. We're actually kicking off our walk season this weekend in Kansas City. And then next weekend, we will host our Chicago Walk and our Anywhere Walks, which you can quite literally participate anywhere in your own communities. And so there is still time to join us. If you would like to, we would be more than happy to help you get registered. And I think someone will probably pop a link in the chat for us so you can get more information. I would also share that if you want to walk with others but don't have others to walk with, we have created a Together Separately team called Stronger Together. And so you are welcome to join and walk. I know there are several members who will be participating or regularly participate that are going to be joining that team. So let us know if you have any questions about the events, about how to get registered. We'd love for you to join us. But today we're going to talk about the latest in lung cancer research. So we're going to cover really a wide range of topics that were presented earlier this month in Barcelona at the IASLC's World Conference on Lung Cancer. And so before we begin, I do want to thank Regeneron for their support in making the program possible today. I also want to just throw out a couple of housekeeping items on Zoom. We ask that everyone stay on mute. The chat is open, so please use that to introduce yourself, to share any questions or thoughts that you have. And I would also share that the captions are enabled. So they are turned on right now, both in English and in Spanish. And you can turn those off if you would like in the options setting. So without further ado, it is my pleasure to introduce to you our moderator for today's call, Dr. Isabel Preeshagul, who is an assistant attending on the Thoracic Oncology Service at Memorial Sloan Kettering Cancer Center. I'll let you take it away.
Thank you so much, Aubrey. And thank you to everyone that's joining us today. I am so excited to be here with Dr. Stephen Liu and Dr. Rachel Sanborn. We are going to be trying our best to keep it as high yield as possible. World Lung was really a tour de force conference that just happened in Barcelona, and there's a lot to tackle, but we're going to try to go through things that are impactful and present it to you in a digestible way. So I'm going to go ahead and introduce my very special guest today. First, we have Dr. Stephen Liu. He is the Division Chief of Hematology Oncology, Associate Professor of Medicine, and the Director of Thoracic Oncology, Head of Developmental Therapeutics at Georgetown University Lombardi Comprehensive Cancer Center. Stephen, so excited to have you.
Thanks for having me. It's always a pleasure.
And we also have Dr. Rachel Sanborn, who is the Medical Director of Clinical Research, as well as Thoracic Oncology Program, as well as the Medical Director of the Phase 1 Clinical Trials Program at the Earl A. Childs Research Institute at Providence Cancer Institute. Welcome, Rachel.
Thank you so much. I'm really happy to be here.
Likewise. So one other thing that I think I should mention is that Lung Cancer Research Foundation has an incredible amount of committees, but one committee that is very near and dear to me is the Education and Engagement Committee. And we are lucky enough to have both Stephen and Rachel as committee members contributing to events like this and helping us shape the future of LCRF. So thank you both for your contributions there. So we are going to dive right into the first topic. And I feel like unless you've been living under a rock, I feel like the overall survival of FLAURA2 came out and just kind of took us all by storm. So if you're not sure what I'm talking about, we are talking about people with lung cancer that harbor EGFR alterations. And if you were to ask us probably about 2-3 years ago, we would be singing osimertinib's praises and talking all about osimertinib, and then sort of mentioning about clinical trials that we have in this space, but nothing else really coming about. But over the past year, we have had approvals in this space, which is very exciting, but it just makes seeing patients with lung cancer who harbor EGFR alterations, specifically exon 19 and exon 21 L858R, much more complicated in a very good way. When a new visit used to take maybe, I would say probably 45 minutes to an hour to really go in depth and make sure that we have informed and shared decision making. I now feel like we need like a good chunk, at least 2 hours for these patients to really dive into the data and explain to them what this treatment landscape looks like. So I think let me just kind of get a pulse on the situation between both you, Rachel, and Stephen. How do you go about handling when you see a patient with stage 4 non-small cell lung cancer, treatment naive, never been treated before? How do you go about this discussion with your patients initially?
I'm
Rachel,
happy to.
Stephen, go ahead. Yes.
Yeah, I'm happy to start. I think that you're right. The climate's changed a bit, but I think for the better. It's complicated because we've seen progress. And in 2018, we learned that osimertinib was superior to the older generation EGFR TKIs. It was a better drug in every regard. It was safer. It worked in more people. It worked for longer, and it translated to people living longer. It was an easy decision. But in 2018, while a progression-free survival of 18.9 months was best in class at the time, over time that became not good enough. To start on a drug like osimertinib, which is well tolerated, and have that work for a year and a half, while that was better than the older drugs, clearly there's room for improvement. And I think that we'll all agree that 18 months is not really a long period of time. And so we've been looking for something better. And now we have things that are better, combination therapies that when given in the frontline setting, when given as initial treatment, offer longer periods of control. They keep the control for longer periods. We didn't know if that would translate to people really living longer, but now we do. So we have 2 combination therapies, the Mariposa regimen, which is amivantamab and lazertinib, and then, as you mentioned, FLAURA2, which is osimertinib plus chemotherapy. And giving these combinations kept the cancer under control longer, and that did translate to actual measurable survival gains. But it comes at the cost of more toxicity and a very different type of lifestyle, because now you're talking about infusions or injections. So I think that really it is a discussion of what the data is, and it is a process where we have to outline the good and the bad, the pros and the cons. With these newer combinations, we can achieve longer survival, but it comes at the cost of an infusion, in the case of FLAURA2, every 3 weeks. Side effects from chemotherapy, which for many are manageable, but I think that word means something different for different people. So I think it is describing what life is like with that, and what outcomes we see. I think that a few years ago, it was more, in whom should we think about combination therapy? I think now, with clear survival benefit across both regimens, I think my attitude has shifted a bit, and it's more starting with combination therapies, and maybe who is not right for combinations. But is ultimately it's really the patient's choice. It's not you or I that need to go through these toxicities or change our life. And so everyone has different priorities, different circumstances. So I think it's really a balance of the pros and cons with each approach.
Well said. Rachel, do you have anything to add in that space?
Well, I would really agree with both of you in this, and particularly with Stephen's comments about how do we think about what the role is of the combination now, rather than selecting like who should have an escalation. It almost feels like we have to think about who is more, who may need a de-escalation approach almost. That being said, though, when I'm discussing this with a patient, I will start at the beginning, and I will start with discussing what the evidence is with osimertinib and what the side effects and the risks are and the timelines are with that, and then take it one step at a time through each of the regimens, so that we talk about single agent, we talk about osimertinib with chemotherapy and what that means, and then balancing that also with the discussion of amivantamab and lazertinib and what that means, as we work toward finding the options that are most appropriate for the person who's experiencing this, and what they feel like is going to be the best fit as we are working forward. And so those conversations are very, very long. They're very difficult. And then throw into that when we may also want to then be at the point, if it's appropriate, of adding in a discussion about a clinical trial. All of a sudden, these are really enormous visits that really many times need to take place over a couple of them so that people have time to digest the information and consider it, talk it over with their family and loved ones, and then be able to have the time to loop back with questions as they've had time to sort through.
Yeah, we all have different perspectives, and I'm sure that both of you have presented the exact same data and options in the exact same way and gotten very different reactions, where someone might hear the side effects and say, well, with a longer survival, clearly that's worth it. And in the next hour, the exact same discussion, in light of these side effects, it's absolutely not worth it. And I really think it depends on the person. And we have different situations. There are some people where, intravenous infusions every 3 weeks just aren't a possibility. Maybe it's childcare, maybe it's employment, time off of work, where this is just not a reality. This is just not something that I can do at this stage in my life. We're not ready for this. Whereas others say, survival really is the absolute most important thing, and we can get through it. I think what's really important, though, when we start these treatments is that you're not locked in to like a 30-year mortgage, that we can adapt, that at no point in time is anyone meant to suffer through treatment. So if we start a treatment, a combination therapy, and it is too toxic, the side effects are just not acceptable, we make a change, whether it's lowering the dose, changing the intervals, taking away some of these extra drugs. We can adapt based on how people do with the different regimens.
Yeah, and I think there was a comment put in the chat that actually is very helpful. So just to sort of orient everyone on the call, we're talking about patients with stage 4 non-small cell lung cancer who harbor EGFR alterations who have not received treatment yet. So we're talking about frontline treatment. Right now, we have 3 options, right? We have osimertinib, single agent alone, 1 pill. We have the FLAURA2 data, which is what we're going to talk about a little bit more, which is combining osimertinib and chemo. And then we have the MARIPOSA data, which is combining amivantamab, which is an IV infusion, MET EGFR and bispecific, and lazertinib, which is a similar pill to osimertinib. So we have 3 options. We have a pill plus chemo, or we have a different pill with a different type of IV infusion targeted therapy. And as Rachel had said, we have clinical trials. So needless to say, there's a lot to be said. Prior to World Lung, we knew that there was a progression-free survival benefit, and we knew there was a signal for overall survival in FLAURA2, which is combining chemotherapy with osimertinib right off the bat. But we had confirmed overall survival, which was very exciting, looking like at a benefit of overall of 10 months when you're getting OC plus chemo versus OC alone. But can you break this down a little bit for me? What was your initial take on this? Did this convince you that like this should replace OC? This is going to replace anyone I would give Ami-Laz to? What was your take on this data, and how has it changed your practice, if at all?
Well, maybe I would say, first of all, we don't know between thinking about, we know that chemotherapy with osimertinib improved overall survival compared with osimertinib alone. We know that amivantamab and lazertinib also improved overall survival. Between those 2 regimens, we don't know which one may be, quote, better, even just purely in terms of the numbers. If we put it in perspective from the numbers that you were just talking about with chemotherapy and osimertinib, in the MARIPOSA regimen with amivantamab and lazertinib, then with the overall survival, when that was presented, the overall survival with amivantamab and lazertinib had not yet been reached, was a little over 36 months with osimertinib. So the OC arm was about identical to what FLAURA2 had for its survival there. Now, the way that the statistics were designed for amivantamab and lazertinib, there was the differential, and that was statistically significant. But the actual hard number of it, we don't have to be able to compare. At the current time, the estimation there was going to be at least a 1-year improvement over the osimertinib overall survival, but it doesn't have an exact number. So the hazard ratio, the risk difference between, was very similar for FLAURA2 and amivantamab lazertinib. We look at a 10-month difference, a 10-month improvement with the chemotherapy and osimertinib. Now, does amivantamab and lazertinib with an estimated more than 1 year mean that it's better? No, because we don't have that in comparison. So we have to look at those and say, it's not something where I'm going to say, well, this is definitely going to supplant my choice between them. I think it still gets back to decision making. We have to talk about the numbers with people. So I think that either way, if we think about, if a person asks, what is the best regimen for my survival, we're going to talk about those combinations. And then we're also going to talk about what those traits are.
Yeah, I was impressed by the data. We had seen a bit by press release, but these were our first look at the actual numbers, and I was impressed. I think that the translation to improving survival, was not a given. When we think of the FLAURA2 trial, patients were randomly assigned to either get osimertinib alone or osimertinib with chemotherapy. And what's a little different about this study compared to Mariposa is that if you started with osimertinib, when the cancer started growing, you could then switch over to chemotherapy. Chemotherapy is widely available. That wasn't part of the trial. But when you came off of the study, you could just receive chemotherapy. We refer that as crossover, where you're receiving that extra treatment later. And so to me, because most people, almost 80%, received another treatment after osimertinib, and for most people that was chemotherapy, there was a chance that could have negated any survival benefit. That giving those drugs in sequence maybe meant you would live the same as if you gave them together. But that wasn't the case. That even with that crossover, even though people could get chemotherapy after osimertinib, the survival difference was there, which really meant giving them together at the beginning made a difference, that the sequence mattered. That wasn't to be assumed. And so I think demonstrating that was important. And I think it really validates this as an option. But as Rachel said, I completely agree. It doesn't mean that it's better than the amivantamab lazertinib combination. It means we have two combination options that improve survival over pill alone to about the same degree. We do not yet have the tools to tell us if one regimen is better than the other for a given person. The main differences I see between these two regimens are the side effects. Both of them have side effects. They're very different side effects. And I think that really will tailor which is right for a given person.
I think you're totally right. It's all about treating each person's cancer and each person's journey, and what looks normal and like very obvious to one person might not ring true to someone else. So I think we have to think about each person individually, right? But that kind of takes me to the next step in this conversation, because there was some data back from ELC when FLAURA2 first came out, because we're always trying to figure out, well, when we have these options, is there a signal that tells us, well, who might do a little bit better? Or how can we steer this conversation to give our patients as much insight to say, listen, it does look like there's an overall survival benefit, but if you're kind of on the fence, these patients with these characteristics seem to enjoy just a little bit more of a benefit, right? So back then it was patients that had EGFR exon 21, L858R insertions, and also those with brain metastases that seemed to enjoy a little bit more of a benefit. And they looked even deeper into other patient characteristics from FLAURA2 that kind of maybe give us a gleam a little bit about who might enjoy more of a benefit. So are you using some of these factors to help shape your conversations, like TP53 co-mutation, positive ctDNA at onset, or are you not really buying into that data?
I'm not really using those right now to guide therapy. When I think that there are groups that generally have a worse prognosis, meaning a cancer that's a little bit harder to treat. But I think the benefit from combination therapy really is across groups. So to me, it's something that I would offer and discuss to all patients. And I'm starting from a place where I would probably recommend combination therapy for most patients. But again, we tailor the specific regimen. And I want to stress there's nothing wrong with using osimertinib alone. I think especially since the field is evolving quickly and our next line therapies are getting better, that for a lot of people, that is a rational choice. That's the best choice for them. And I'll be supportive of that.
I would agree with that as well. I don't think that many times I'm thinking, okay, these are the only things that I'm going to use to select to use a combination regimen with. But when we start to really look and understand, it's been pointed out by other people that many people who have stage 4 non-small cell lung cancer with an EGFR mutation. Here we're talking about exon 19 deletion or L858R mutations, have some other high-risk feature, whether they have a TP53 alteration or a TP53 and an RB1 loss as another marker in their tumor, or whether it's brain metastases or whether it's liver metastases. There are not too many people who don't have any high-risk feature. It's sort of a kind of picking which one is there. And so right now, I think that it's more of the approach of thinking about for whom that may not be a good fit as the treatment, as opposed to who we should, who doesn't need that much.
Yeah, I agree. And it's also very, very patient specific. There are, perhaps someone that, doesn't have the means to make the transportation, or chemotherapy is just not in the cards for them right now. Or they want to see how they do on OC first, right? I think someone in the chat brought up the really important concept of sequencing, right? There's the fear of if I use all these weapons all at once, and for some reason it doesn't work, well, what am I going to fall back on, right? If you start with OC and it doesn't work as well for you, you can always add chemo on the back end. So there's still that debate, and I think that there's still a lot to be said about that. I'm certainly not shifting OC single agent by the wayside by any means in my practice. But I do think, speaking about sequencing, we do need to kind of think about, unfortunately, if these drugs that we are all so excited about with osimertinib, OC plus chemo, amivantamab, and lazertinib, whatever they may be, unfortunately don't work so well for you, we still don't really know what's the next best thing to do for these patients, right? How do we sequence? What do we do? And there was actually a study that called COMPEL, which was looking at patients with stage 4 non-small cell lung cancer harboring EGFR alterations that were on osimertinib that progressed, outside of the brain, in the chest only. And actually, what I thought was kind of interesting about this study was that they actually randomized patients at that point to receive OC alone or OC plus chemo. And actually, it showed that the patients that received OC plus chemo actually had better CNS protective effects, right? The risk or the development of brain metastases actually decreased. So that was kind of interesting. And it made me think maybe chemo does have some CNS efficacy, or maybe it's just that patients needed OC a little bit longer, or was the combination. When patients have, progression outside of the brain, just in the chest alone, what tends to be your practice if they're on OC only?
Well, so I think, first of all, if we look across all of the combinations, we didn't expect originally chemotherapy to add improvement for brain protection over osimertinib. Osimertinib was the talisman to be able to help protect in the brain, because chemotherapy didn't get into the brain very well. Even with amivantamab as a bispecific antibody, which is a large antibody that's in the body, it wasn't expected to cross into the blood-brain barrier, and was not felt to have a confidence to help with CNS protection at that point. And yet in both of those studies with combination, we saw that there was better brain protection with a combination treatment than there was with single agent osimertinib. So all of a sudden, our prior theories have really gone by the wayside, and that factors into those discussions. But then when you have a person who's progressing on osimertinib alone, what do you do next? I think that, first of all, if we're talking about, you have a lot of decisions to make when a person is progressing in the brain. We have to look at how many tumors there are and what size, and if they are causing symptoms, because one of the first things we have to think about is changing systemic therapy enough, or is this a disease process in which a person needs local intervention with radiation, either with stereotactic radiosurgery or other in addition. So you have to start with that decision-making process, and many times we have the radiation oncology team also weighing in. There's more confidence that if we change systemic therapy, it's going to work better if there are smaller tumors and if there is not a tremendous amount of disease progression. But I think that in that situation, considering adding chemotherapy in is a very reasonable thing to add that on at that point rather than make a full switch. Stephen, I'll let you jump in.
Yeah, I agree. It's all about the details. And so when we look at progression, it means that the cancer's grown in some way, but there's lots of different ways it can look. And if it's just in one spot and osimertinib is working for most of the cancer, I agree. Just target that one spot with radiation, sometimes with surgery. But if it really is a more global issue, we try to do a biopsy. We try to understand how this cancer has changed and really inform next line treatments. What we're looking for is something like transformation to small cell or to squamous cell, which is uncommon but not rare, and which requires a very different type of treatment. We look for specific mechanisms of resistance we can target, like amplification of MET. And if we can understand how this cancer became resistant, maybe we can tailor or personalize a combination that restores control. But in cases where we can't do those biopsies or we don't find anything, I think that my standard has been chemotherapy-based treatment. And the two approaches I would say would be chemotherapy plus amivantamab, that's based on the Mariposa 2 trial, or chemotherapy with osimertinib based on the COMPEL study. And I think that continuing the osimertinib with chemotherapy is something that I think all three of us have done, but we did not have evidence to show that it was helpful. Now we do. And so from the COMPEL study, which was a relatively smaller study, underpowered study, but it did show that there was, seemingly some benefit to continuing that osimertinib, sort of reaffirming what has been our practice, I think, for many years.
I think I'll throw in a clarification that my discussion with that was based on the thought of brain-only progression at that point with no other progression. So outside of brain, yes, I think if there's brain-only progression, then trying to get a biopsy to rule out transformation is really a challenge to do unless there's some very, very large tumor. So they're kind of these different scenarios you have to look at in terms of the where of that progression too.
Yeah, and I think speaking about the brain, we have some exciting other options in this space as well. We all know about the data from Harmony, which is looking at a drug called ivonescimab, which is a dual VEGF and PD-L1 inhibitor. And we also have heard about the approval of datopotamab deruxtecan, that's a mouthful, or Dato-DXd in this space, which is an antibody drug conjugate that has been approved to give to patients with stage 4 non-small cell lung cancer harboring EGFR alterations based off the Tropion lung study in the second line and beyond setting. So I do kind of want to get a sense from both of you if you've given this drug at all, if you have any experience with it on trial or not, because I've actually had a couple of patients ask about it, and I'm just curious what your experience is so far.
Sure. So those are both drugs that I think could play a role. Ivonescimab is a bispecific antibody that is approved in China, but is not approved in the US. And the study that you referred to looked at people who had already had an EGFR inhibitor, and then they're randomized to regular chemotherapy, which would be a standard option, or chemotherapy with ivonescimab, this antibody. Adding that antibody did improve progression-free survival, kept that cancer under control for longer, and that was pretty noticeable. But it did not translate to a significant difference in survival. The study, which was presented by our colleague John Goldman, showed that it was close, that it almost did, but it didn't quite meet significance. And so I think what that means is even though the drug is approved in China, it is unlikely to be available in the US. Whether there's some benefit, I think is debatable. But it was close. There was a trend in the right direction, but it simply won't be an option in the EGFR setting. It may be an option for other types of lung cancer without an EGFR mutation, or waiting for some more results that'll be next month and then later in the year. But right now, probably not going to be an option for EGFR. That's in contrast to datopotamab. Datopotamab, the antibody drug conjugate, is approved in EGFR after osimertinib, after chemotherapy. It is not a chemotherapy agent, but to be clear, the side effects can be pretty similar to chemotherapy. We can see nausea, can see lowering the blood counts. I think the important side effects, it can cause some ocular side effects, some often just dryness of the eyes. a mucositis, sort of sores in the mouth, maybe a little more significant than what you would see with osimertinib, and that can affect quality of life. It can affect our diet, the things that we eat. Can be treated, but it is an important side effect. And then there's a risk of something called pneumonitis. Pneumonitis is an inflammation with the lungs, which can be a serious side effect, and we can see that with the antibody drug conjugate. So not a chemotherapy agent, a little more localized, but it does have important side effects. It's an active drug, though, and one of the points you brought up was the CNS activity. And what we learned at WCLC was datopotamab does have some CNS activity in patients that had cancer that spread to the brain with no radiation. We did see a response in, somewhere between 35-40% of patients where we saw a response, which I think is meaningful. And the vast majority had at least control. So to have another drug that is active, that works in a different way, and that can provide some activity within the brain, I think is an important advancement. Importantly, in that study that showed there was some brain activity with datopotamab, if we looked at standard next-line chemotherapy with docetaxel, the response rate was 0. And it's hard to get lower than that. So we saw about 37% compared to 0%. So I think that it's a welcome addition for our patients.
I think as well along those lines is we're going to see, we already know that there are a tremendous number of these antibody drug conjugates that are in development. They're still earlier in investigation, but there are a lot of ways in which they're looking at trying to use a novel target to try to improve how we get the drug conjugate part, the chemotherapy part of that antibody more effectively to the cancer cells. And this area, I think, is going to be exploding in the next few years, and we're going to see a lot more studies coming out that I think we're going to have a little better confidence that there can be some reach into the CNS with these, given what we're seeing before with these other ADCs.
100%. Always look to trials. Once we see data presented, realize that often that data is already immediately years old. And so having trials, newer drugs, we're getting better at drug design, synthetic biology, medicinal chemistry. Our drugs are rationally created. And so I think that the drugs are getting better. Always look to trials.
Yes, definitely. I think I'm always on my soapbox about increasing access to trials, and removing barriers. So I definitely hear that. And just to chime in a little bit about the datopotamab deruxtecan experience, I think that, the stomatitis has been legit. I've seen patients, sometimes if you suck on ice, that can be very helpful while the infusion is going in and afterwards. Of course, obviously the mouth rinse. The keratitis or irritation of the eyes is something that I've seen initially be underreported. So I think if you are on this drug, it's definitely something to think about, and you should be seen by an ophthalmologist at baseline. And also the nausea, which I think is underplayed, but antibody drug conjugates are extremely emetogenic or can cause a lot of nausea. And oftentimes I think they should be moved into, or they already may be moved into that category in our NCCN guidelines, but it's almost as if you're getting cisplatin or carboplatin. You should be also having olanzapine. You should be having an aloxi or a long-acting antiemetic that's given to you the day of treatment. And also you should have anti-nausea tablets that you can take at home, and even a prolonged steroid taper afterwards. I have found that it can be really impactful. So if you're on this drug or you're thinking about it, datopotamab deruxtecan, it can be given after multiple lines of treatment. It doesn't really seem that there's a limit, which is great. And it does have efficacy, and maybe it can stave off radiation for you, or whole brain radiation in the brain. It does have, that waterfall plot, my mouth dropped. It looked like those beautiful responses. So I think I was shocked by that data. I think of datopotamab deruxtecan as this like big bulky thing. It's not going to get up there at all, and it penetrated the blood-brain barrier beautifully. So I was thrilled with that, but it is a tough drug. So so I think if we were to just kind of summarize this section about patients with EGFR alterations, it's really that there's multiple options, right? And you really need to just tailor to each person's individual desires and priorities, and what's most important to them, I think, really.
Yeah, well said.
Yeah. And this is like a great segue for me to just introduce Dr. Wozniak to talk a little bit about the exciting endeavors that LCRF has coming up and partnerships that we have for research funding in the EGFR and HER2 alteration space. So Dr. Wozniak, take it away.
I won't talk very long. We have a lot going on, which is really exciting. Most recently, we are planning to give a $1.5 million grant for EGFR research. It's a Team Science Award over 3 years, and we're able to do this because of a very generous donation. And we're really excited. And the whole idea is to develop novel therapies for EGFR-driven lung cancer. We also actually have all along been funding projects that have to do with EGFR. We have two grants, they're early investigator grants that are that we put out early in the year. One's leading edge and one is overcoming resistance. And both of those really get a lot of letters of intent that are looking at EGFR. In terms of HER2, we have had a lot of activity lately. We funded 2 awards that were recently given, one to a researcher at Yale and one to a researcher at MD Anderson in HER2 research, and that's because of generous donation by Bayer. But now we are in the process of doing additional HER2 grants, a Team Science Award, that just started in terms of getting applications, and some early investigator awards as well because of a generous donation from Boehringer Ingelheim. So a lot of activity.
That's so exciting. I love hearing that, that we're still able to move the needle forward, and we have such bright scientists, bright physicians, and other practitioners looking to partner with us here. So that's very, very exciting. And thank you, Dr. Wozniak, for that update. So we're going to move on to a different target. We're going to move on to a target that is not as common, but definitely had some exciting data that was reviewed. And that is the ROS1 fusion target. This is a target that's often seen in patients similar to patients that have EGFR alterations in patients with rather light to no smoking history. It's not as common as EGFR, but it's definitely something to look for. You always want to make sure that you have full next generation sequencing testing, right? DNA as well as RNA to not miss these fusions like ROS1. And we do have, some approvals in this space, but the study that we're going to be talking about today is the AROS-1 study, or AROS-1 study, with a drug called zidesamtinib. So this is a targeted ROS1 drug that actually really impressed me. We actually had this study here, and I was impressed by the data. It was wonderful to see patients on study and how they were doing. And I would love to just hear both of your takes on this presentation and this drug, and how you think it may, come to fruition, and where you think it would live in the ROS1 space.
So as we were part of the study as well, I'm one of the co-authors from this, and I think it's very exciting, and I think it's really a testament to where we've come with drug development, drug design. Zidesamtinib is a ROS1 inhibitor, and we have several ROS1 inhibitors that are approved. Crizotinib, entrectinib, repotrectinib, most recently taletrectinib. Now, if you look at those first 3, crizotinib, entrectinib, repotrectinib, these are active drugs for sure, but they don't only target ROS1. Crizotinib also targets ALK, it also targets MET. And if you look at entrectinib, repotrectinib, drugs that are I think a little bit more active in the brain, which is important, they are also active at NTRK, and they are approved for use of cancers that have an NTRK fusion. And so when we target NTRK, if the cancer is relying on NTRK, then that's going to be a positive effect. But if the cancer is relying on ROS1, and we're giving a drug that also blocks NTRK, we're going to have a lot of side effects for blocking NTRK. There are consequences to blocking NTRK, and those can be significant. NTRK is responsible for proprioception, the sense of where we are in space. So when we block that, it can affect our ability to walk. It can lead to ataxia, imbalance, falls, which can really impact quality of life. NTRK is responsible for appetite. So when we block that, we can see weight gain, we can see significant weight gain, which can really be detrimental to patients' quality of life and to their health in general. It can affect pain or nociception. And so we have this pain withdrawal syndrome. There are a lot of side effects with blocking NTRK. Zidesamtinib is designed to be a selective ROS1 inhibitor with no activity at NTRK or very little. So by its design, we won't have activity at NTRK, which means you can't use this for an NTRK-driven cancer, but you're also not seeing those types of side effects. And as a result, I think the drug is going to be much better tolerated. In addition, because you're not limited by those side effects, maybe you could give a higher dose, and maybe that means that the drug will work a little better in terms of controlling the brain, in terms of the duration. And while it's an early look, and this will take a little bit of time to get the full maturity, what we saw when we give this drug as treatment number one, as initial therapy, was the response rate was about 90%. 90% is a pretty high number. And when we look at the duration of response, we're nowhere near the median or average duration of response. And the number of responses that are still going at 1 year was 96%. It's a pretty high number. So I'm excited at the prospects for how long this drug could work. And I really do think this has a chance to be the best in class.
I would add on that one. First of all, we were not a site for this trial, so I have not worked with this agent, but I was really struck by a couple of things when watching the presentation. The first was indeed although the numbers are small and the data is early, looking at the high response rate in the first line setting with the fewer toxicities, I think was really quite striking. But then also looking at in the groups of people who had been treated, who had received prior therapies, that included groups of people who had also already had previous treatment with taletrectinib and repotrectinib, and so highly active agents. Now, with many other targeted therapies for different types of sensitizing mutations, when we're changing to the next therapy, many times we're expecting to see a pretty short duration of disease control, or relatively fewer people have a response to that next treatment. So we generally expect quite a drop off for how many people the next thing is effective in. And the number of people who had a response, even with those sort of newest generation agents, once going on to this, was really, really caught my eye and my attention with this. I'm really excited to see where the rest of the data matures, but I do think that it's going to have a place moving forward earlier in treatment.
Yeah, I think you hit all the highlights, both of you, that I could have wanted to say about this. I'm thrilled that perhaps there may be some CNS efficacy, and maybe it's a little bit better than what we have out there already. But the tolerability, and I say that term very loosely because it is certainly not me tolerating these drugs, but from what I could observe and from what was reported, it seemed to be better than what some of the other patients have experienced on some of the other drugs, right? The dizziness can be incapacitating. And we think of those drugs, we affectionately call them dirty kinases, right? They just attack many different things. And the fact that there's less TRK in this drug, I think, is why we're seeing less of those withdrawal pain syndromes, right? Less of the dizziness and the ataxia. But it is still a drug, and it is still tough. And I am certainly not trying to downplay that by any means. And I think we just need to figure out what's the right dose, and what's the right dose for everyone may not be the right dose for you. So stay tuned, but I definitely think there's a signal here. I was excited about this data, and I think more to come in this space. So I am going to sort of shift us over to open up the conversation about any other targets or topics that you were excited about that you want to talk about that was presented at World Lung before we move on to the early stage, locally advanced setting.
Well, we did see a lot of activity, or sort of some of the newer drugs in terms of the antibody drug conjugates. We mentioned datopotamab, but there are, as Rachel was alluding to, some new agents, I think largely out of China, that are showing a lot of activity. I think our drugs are getting better. And I think it's exciting to have some of these newer options. The waterfall plots that we're seeing, the responses are sort of phenomenal across the board. So to have so many new antibody drug conjugates, we saw some data for Isabel, which is a bispecific antibody drug conjugate targeting HER3 and EGFR. This is a drug that was reported mostly out of China, but there are studies in the US, and we're seeing very high response rates. We're seeing combinations in the frontline setting with osimertinib. So while we're thinking about amivantamab lazertinib, or we're thinking about chemotherapy osimertinib, could we see ADC plus TKI in the very near future? And I think the answer is probably yes. So I think it's an exciting time, and drug development is moving along a lot quicker than it had when we were in the earlier parts of our career. And I think that's really a good thing.
I'll add into that a very similar situation with the bispecific antibodies. We have seen these advances with amivantamab, say, for example, as a bispecific antibody. Looking at ivonescimab, we didn't see we didn't see what we had wanted to see. And it shows us that you have to select your targets very carefully. Not every bispecific is going to be as equally beneficial. But I think that if we look at the number of bispecific antibodies that are currently under investigation, I mean, it's an entire array of different types of concepts, of different types of pairings. And we just have to look, say, at the small cell arena, which we're not going to talk about right at the moment, but look at what's happening, say, with T-cell engagers in that space to see that there are paths forward with activity there that are going to be, I think, really coming onto the scene in the near future as well. So that class of agents also is something that I really look forward to seeing.
I echo both of what you both shared, and I thank you for that. I think what we're seeing is maybe combination therapy is really the direction that we're headed, right? We're combining two different targets on one head, right, with amivantamab, but then we're looking at ivonescimab, we're looking at these antibody drug conjugates with over 300 in development right now, and probably more than that. So I think the future is looking like options, which I think is what we want to hear, and also what our patients want to hear, right? Because as oncologists, we are obviously presenting plan A, but we always have to think about B, C, D, E, and if E doesn't work, is F going to work out? What about G? Is H available? At what location? So we're just constantly having to sort of play chess at all times on the back end, trying to make sure that, you know, if something happens, we're prepared with options, because you never want to walk into a room with egg on your face and not knowing what to do. And that happens, and it is devastating to the family, and it's devastating to us. And we have to kind of know how to navigate, and having options means having hopefully more time, but not jeopardizing quality of time.
I totally agree. And I use that chess match analogy all the time in my discussions with people as well.
Glad to hear I'm not alone on that one. So I am, obviously we can always jump back to the advanced stage setting, but I am going to move us into the early stage and locally advanced setting a little bit, because we are blowing through this time so quickly, and there's so much to be said. But I do want to talk a little bit about early stage lung cancer and what that looks like, right? So early stage meaning cancer that we are treating with intention to cure, combined modality treatment with surgery, radiation, neoadjuvant, adjuvant treatment. There's so many terms: major pathologic response, complete pathologic response. What do all these words mean? So let's kind of do a little bit of a terminology review for everyone first, and then we can kind of dive into the data a little bit more. So I'm going to call on you, Rachel, first. When you're talking about neoadjuvant therapy and major pathologic response and complete pathologic response, how do you explain these terms to your patients and family members so they can digest this information?
Great question, because these are a lot of terms when I'm talking with a person who, particularly when somebody's been newly diagnosed with lung cancer, we have to address the issue straight up that they're going to be learning a lot about something they never wanted to have to learn about. And so it's a lot of intense information to go through. In the neoadjuvant setting, when a person has a lung cancer that looks like it will be able or may be able to be removed with surgery, we then talk about adding treatment like chemotherapies and immune therapies before the surgery, which is trying to accomplish a couple of things. Number one, it's trying to directly be toxic to the cancer that we know is there. But then also it is trying to attack micrometastatic disease, which means tiny little seeds of the cancer that we cannot see with the imaging technology that we have right now. And that it's trying to then go through the body to do all at once. And particularly with adding immune therapy, the other part of what we're trying to accomplish is help to train the immune system when the cancer is there and intact to try to be recognizing and attacking that cancer that is in there. And doing that as our first step before moving to the surgery. And then in terms of the surgery itself, we're using what comes out of that surgery, that final pathology, to look and say how much of the cancer responded or was killed. And in terms of going through what a major pathologic response is, at least in those conversations, it's hard to get into the weeds about a specific percent as much as we're discussing if there's a significant portion of that cancer that has responded, but still maybe some living cancer cells remaining. Whereas a complete pathologic response means that when that cancer is removed by surgery, that the pathologist, in looking through all of those sections, is not able to find any living cancer cells in what has come out. And then we will use that to talk about moving into the next step of what types of treatments, specifically looking at the consideration of immune therapy after surgery, we may be adding to try to help reduce the chance of the cancer coming back.
Sorry, I love those visuals. I think that's very helpful, right? To think about, giving someone treatment before they go to the operating room. And when that tumor comes out, how much of it is big dead tumor and how much of it is there still some living cancer around, right? So I think that's very helpful. And the reason those terms are important is because we use that finding, right, to help us determine maybe would someone benefit from more treatment after, which is known as adjuvant, right? So, Stephen, how do you use in someone that's already received chemotherapy and immunotherapy in the neoadjuvant setting or before they go to the operating room and then they have a resection? How would you use that information of major pathologic response, complete path response, or whatever it may be, and maybe some other features to determine if they should then receive adjuvant therapy after?
I think it's still an open question. I don't know we have all the answers. I think that it's clear that if you have a pathologic complete response, zero viable tumor after neoadjuvant therapy, those patients do very well afterwards, with or without further therapy. We don't yet know if giving more therapy provides any additional benefit. The studies that we have weren't designed to answer that question, but studies that are going on now will answer that question. And so stay tuned. We're going to try to get the answer to that question. What we do know today is if we do have a pathologic complete response, the outcomes are very good, whether we have more therapy or not. If we do not have a pathologic complete response, there's still residual tumor left. I think the standard often is to continue the therapy afterwards, but still an open question as to how much benefit that adds. And I think it's important to distinguish that when we talk about the impact of this pathologic complete response, we are really referring to a world of chemotherapy and immunotherapy. And for targeted therapy, which is a space where these drugs may also have a role, it probably means something different. So the context is a little different depending on specific drugs, depending on the specific type of cancer.
Perfect segue. That was literally my next question. So we have focused so much energy on chemoimmunotherapy followed by immunotherapy. And, our patients that have driver alterations that we are now learning about in the early stage setting are kind of waiting with bated breath of like, is targeted therapy going to be a role of my treatment? How does it get introduced? And we know that based off of the ADAURA data that was presented at ASCO a couple of years ago that showed that patients had resected lung cancer, went on to get adjuvant, right, chemotherapy, and then osimertinib for 3 years had a beautiful survival advantage, right? But what about giving patients osimertinib before they even go to the operating room, right? The NEO-ADAURA data that was presented by Dr. Jamie Chaft at ASCO this past year, I feel like it didn't get as much excitement as it should have. And I'm just kind of curious what both your takes are on this. Are you using this? Are you believing in the data? Talk to me a little bit about what your thoughts are. Rachel, I saw you smile first.
Okay. First of all, I think that the NEO-ADAURA data really helps to highlight the absolute importance of having mutation testing done at any stage of the disease before treatment is started. And because there are so many times still where we hear about people getting immunotherapy because of a tiny biopsy, and then at the time of surgery being found to have an EGFR mutation. And then we are stuck with looking at the risk of adding osimertinib after recent immunotherapy. We saw in that data that in the NEO-ADAURA study, which was a study looking at chemotherapy or osimertinib and chemotherapy, that adding osimertinib as a targeted therapy before the surgery helped significantly improve the responses and over chemotherapy alone. And so we saw a significant major pathologic response improvement for those patients. However, we don't know yet in that data whether that's going to, what that means in terms of relative cure rates. So that's going to be something that's early in there. But adding the osimertinib earlier did show benefit.
I think in that study, most patients are going to continue osimertinib afterwards in the adjuvant setting. And the challenge with that study is that giving osimertinib in the adjuvant setting provides so much benefit, such a substantial benefit in terms of recurrence and survival even, that it's going to be hard to really isolate the value of giving it upfront. While I think the data are important, I actually think the true value of these neoadjuvant studies is going to be a little different. When we think of neoadjuvant therapy with immunotherapy, I think that is changing outcomes for the individual patient. For targeted therapy, I don't know that that's the case. And I don't know that giving those targeted therapy drugs before surgery is necessarily going to help the specific patient. What I think it does help, though, I think it helps the field. Because if we give this targeted drug to a bunch of patients and we see that there's still residual disease for most patients at the time of surgery, what we also have is the tissue sample of that residual disease that we can now study. And so now our scientists can go and really look closely and try to tell us, how are these cancer cells surviving? Why do we not see all the cancer cells die from osimertinib, from alectinib? How are cells persisting? To me, the neoadjuvant space is the perfect platform to really understand drug persistence and inherent resistance. And by understanding that process a little better, we can then go back and design newer strategies that can maybe eradicate all the cancer in the next patient. And then maybe we can start using those instead of just in the early stage, in the later stage. So I think this is where drug development is going to go, where we're going to learn how drugs work and how to devise rational combinations. But overall, in this setting, I think giving the targeted drug before the surgery may not be as critical for the individual patient, but I think the research is very important.
And I think you highlight a very important nuanced part of the NEO-ADAURA study about, it's new, right? It's early. We don't know survival data. We know that it improved path complete response rate, but was it the OC or was it the chemo? And what's the right option there? So when you're giving patients, if you are buying into this and using this data, if you are giving patients OC in the neoadjuvant setting, are you also giving it with chemo?
I think the MPR rates were pretty similar between the chemotherapy OC and osimertinib alone. So if we are using the targeted drug first, I think osimertinib alone will probably get us where we need to go. But I do think it's an open question because in the ADORA study, people that got chemotherapy seemed to do better, although the study wasn't designed to ask that specific question. So I think there is a role for chemotherapy. Giving them together does increase side effects. It's true. But I think that it's something we're more comfortable doing. So I don't know that it's going to increase the major pathologic response rates. I think there's still a role for chemotherapy in most cases. But the specific sequence, I don't know if we know that it matters yet.
I will say that when we looked at the curves of tracking out after the median, after the reported number of what happened to the patients, how many recurrences were seen for patients who had gotten chemotherapy and osimertinib in combination versus just osimertinib alone, there seemed to be a drop-off rate later on with more people recurring on osimertinib. Now, those numbers are not mature yet, but that trend on the graph had me concerned and a bit nervous. So I would be more nervous, I think, about using osimertinib on its own, and would generally think about using the combination unless there's some particular problem or challenge that would make that more problematic.
Yeah, I think that tends to be the practice here as well. But more to come. I still present every single case at our tumor board when this comes up because we are very appropriately doing next generation sequencing testing on all of our patients, regardless of stage. But very candidly, sometimes we don't know what to do with this data. And sometimes it complicates things and it leads to, knowing more, but what do we do with that more? And I think more to come on that. There was a very appropriate question in the chat about minimal residual disease and testing for that. In my practice, I don't think I'm ready for prime time for that, as I'm just not sure what to do with that data. But I'm curious if you both, Rachel and Stephen, are implementing this in your clinic as of yet, and how?
So we're just starting here. There are some assays that are out there commercially available. The data is weak in lung cancer, and there are two general classes: a tumor uninformed assay, which mostly looks at something called methylation, different signatures that are associated with residual cancer, and then a tumor informed assay, which uses the surgical specimen to sort of create a personalized blood-based test to look for microscopic traces of that cancer. Those are, I think, more frequently used in other cancers like colorectal cancer, where I think there's a little bit more robust data. In lung cancer, I think we're still collecting that data. It's early, and there's some data, but it's certainly what we're waiting for. What we really want is after someone's had surgery, the question is, are they truly cured? Is there zero cancer? Is there no chance of the cancer coming back? Because if they're truly cured, that means they don't need more therapy, and we can deprive them of years, sometimes indefinite treatment afterwards, which comes at great cost and toxicity. Giving those treatments to everybody means that we will provide it to some people who need it, which is great, but it means we're going to give it to some people who don't need it, which I think we regret. And since we can't tell who those people are up front just by looking at them, we don't have the test, we tend, I think, to overtreat in the US relative to other parts of the world. So that MRD assay, I think, is critical. But the data we have, if we look at the ADORA, they did report some data on a tumor-informed MRD assay, and it just wasn't good enough. It just wasn't there. I think the technology's not there, but I think it will get there quickly.
I would say that I agree. The desire is there. The need is absolutely there. But right now, I agree with is in that we don't have an assay where we can say which is the best assay, which is a reliable assay, which assay can I actually act upon the results with confidence because they are consistent across multiple platforms, across multiple studies, across multiple scenarios. Don't think that we're there yet for me to be able to say, if we use this test and we act in this way, we will improve survival for this person. And so that right now is being plowed a little more in other tumor types. We have not seen what we want yet in lung. I think that will change in the next few years, but right now, outside of a clinical trial, I'm not using that data.
Yeah, and I think, there are times when we can extrapolate from our other medical oncologists, like the hematology world, where they have been using MRD for decades, to really get a better understanding of how deep is this response for each patient. But I don't know if we can extrapolate that yet to solid tumors just yet. I think, I think it's difficult. And also, like, what is our threshold? What is considered, absolutely no minimal residual disease, and is 10% considered good, or 20%, or what is that? And I think, I'm really curious, because I do hope at some point we can get to that point where we can really say, listen, I can't find anything, like not even on a scan, but not even period, nothing. So I think that would be great. I look forward to that. And yeah, I can't wait. So just on that note, I think, picking up on disease and finding cancer earlier is really important. And, while we're working on these therapies, if we could even prevent or pick up on, a cancer diagnosis before a patient may even need to see these therapies, that would be great. So lung cancer screening is something that I think we can all get on our podiums about and shout it from the rooftops. But it falls on our community partners, our pulmonologists, our primary care doctors, a conversation to be had at the Thanksgiving table. So-and-so uncle has a history of smoking, so-and-so cousin is still actively smoking. Think about lung cancer screening when we talk about colonoscopy and pink washing for breast cancer awareness. There should be, there really should be more out there of lung cancer screening. So I know I'm going to call upon Dr. Wozniak again to talk to us a little bit about LCRF's endeavors in this area, because it's very exciting. Dr. Wozniak, are you available to chime in a little bit about this?
I'm here. So we've always been very interested in screening and lung cancer prevention. So every year, one of our grant tracks, it has to do with early detection and prevention. And we do give young investigator grants in this category. Most recently, we're excited to announce a new partnership for a grant, and that's with OUCH. Okay, OUCH means Oncology Advocates United for Climate and Health. And I had to read that, but this is being sponsored by a generous donation from AstraZeneca. And this will be released early next year. The RFP, and it has to do with the effects of air pollution and climate changes on cancer care and outcomes. So this is a new direction for us, and we're pretty excited.
Sorry about that. Are you hoping that this space is going to, and this research is going to possibly shape lung cancer screening for patients that have no smoking history? Because I know this question comes up all the time. And I was just kind of looking very quickly to see, what studies we have available in this space. And I think this might be an area that might be of need. And I'm just curious if this seems to be a direction that you're thinking maybe LCRF may look.
It may be one of the directions. I know there is a great interest in trying to develop models, to actually expand the screening criteria. But it isn't for everybody. Maybe family history, it may be, it's hard to capture exposure to air pollution, but that is one of the directions we hope to go in. In fact, one of our grants from our young investigators is dealing with air pollution and its potential for causing lung cancer in never smokers. So that is one of the grants that we have funded. It's Dr. Hanjani from the UK, and she's come up with a lot of great stuff, and that is one of the directions we are interested in, of course.
I'm very happy to hear that. I think there's been a lot of chatter about this, and also someone speaking up in the chat about ignoring people that have no smoking history. And I'm just so happy to see that this is, we're trying to explore this space for them. So thank you for that, Dr. Wozniak. I appreciate it. So I know I took a quick little pivot to screening and early stage, but I had mentioned we were going to also talk about our patients that have locally advanced cancer, right? So cancer that is determined from a surgeon to be unresectable, meaning there is no role for surgery, but this is not stage 4. So we're still treating with intention to cure. So typically we treat patients like this with combined chemotherapy and radiation. And that is followed by immunotherapy if they have no targetable alteration, or it's followed by osimertinib based off of the LAURA data that was also presented at ASCO by Dr. Ramalingam. So I think in this space, there is some work that's being done. There was a study done by ECOG that was presented sort of based off of the Pacific trial, looking at giving chemotherapy and immunotherapy at the same time with radiation. What was your thoughts on this? Do you think, has it changed your practice? Are you excited about this data? Curious to hear from both of you.
So we're talking about the EA 5181, and
Yes.
our standard treatment had been, as you mentioned, chemo radiation, followed by durvalumab. And for someone with an unresectable non-small cell lung cancer, we think that gives us the best chance at cure. But the question is, can we move things up earlier? And we saw a year and a half ago now, Jeff Bradley presented Pacific 2, which showed moving therapy up earlier, moving immunotherapy to that earlier part did not improve outcomes. In fact, seemed to negate the benefit from immunotherapy. This was another study, A51, also showing that giving chemoradiation with immunotherapy did not translate to an improvement in survival. Really, the survival was the same as giving chemoradiation alone. I think this is, one more in a series of studies showing that combining chemoradiation and immunotherapy for unresectable lung cancer is just not the winning strategy. We've seen it in non-small cell with Pacific 2, with Checkmate 73L, and with now EA 5181. And we've also seen it in small cell lung cancer with NRG LU005. And so it's humbling. And I think it's a reminder that we don't understand how everything works just yet. That, it makes sense on paper that immunotherapy and radiation seem like good partners, but I think the details matter. And it matters what you're radiating, and maybe radiating all the lymph nodes isn't the best strategy when this is where all the work is done. And it matters how much radiation, the doses, the fractionation, all these details probably matter a lot. So it's much more complex than I think we realized. And that's why we have to do the studies. That's why the research is so important. That a lot of the preclinical things, a lot of things that we assume might be better, turn out not to be better.
I would completely agree with that. There's evolving data that is looking at there are times in which we can try to use radiation to help the immune recognition and immune response, but using the doses where we are currently with what's called the conventional doses of radiation haven't been shown to be getting us there. There is a lot of earlier work that's being done, first in lab and then coming into some earlier human studies, looking at lower amounts of radiation, very low doses of radiation to be given with an immune therapy to try to help boost them. But that's being used first and investigated in later stages of disease to look at whether or not that effectiveness is really there in the way that we want it to be before it would be moving into the earlier stages of disease. So I don't think that the concept will be completely over, but it's not going to be used in the way that it's being used right now. So it's going to take some time to really understand that part. There's a tremendous amount of the immune system that we still have so much to learn about. And those nuances, they're improving every day, but they also bring up more questions that we need to understand at each step.
Yeah, I was not surprised by the data either. Seems that neither of you were. But sometimes a study that is not positive, you can learn more from than studies that are resoundingly positive, right? So, and more isn't always more, right? And I think we we follow in these patterns. We think, oh, chemo alone, add chemo IO. It did so well. Add another targeted therapy, add an ADC, and maybe it's something, and maybe for certain patients there's a signal, maybe for certain disease types there is, but it's not one size fits all. But the only way that we learn is to try from these trials, and I think there's science behind it. So I appreciate the efforts, but I think it just further confirms to me that immunotherapy should be given on the back end for these patients right now. Any other thoughts about this before we move on? We also have a little bit of time here to open up the chat, because I know a lot of you have been very busy in here, but if there's any questions you have for Rachel or for Stephen, our experts that we have here today, I can try to field them before we sort of move on to our next topics, because I know there tend to be a flood of questions at the end, and then we end up running out of time. So if there's questions that you have, feel free to put them in the chat. Other than that, I think, is there anything else at World Lung that was exciting to you that you think you want to talk about today, that you want to share with our folks? It doesn't have to be, super granular data. It could be just an overall concept about the way you think things are going, things that you're looking forward to about ESMO, which is a conference that's coming up next in Germany. Curious.
Yeah, I think we saw some interesting things on small cell lung cancer at WCLC as well. We saw a lot of activity for antibody drug conjugates with remarkably high response rates, waterfall plots that look like targeted therapy that we're seeing in small cell lung cancer. We saw an update on maintenance tarlatamab, which is not a randomized phase 3 trial yet, but really showing that when we complete chemoimmunotherapy with durvalumab or atezolizumab, and then move on to tarlatamab before progression, that we saw very long periods of disease control and very impressive survival numbers. And so maintenance strategies, right now we have lurbinectedin, which is now in the NCCN guidelines as a maintenance strategy for small cell. I think in the future we will see tarlatamab, but again, we need to see the data. The study is ongoing now, and so we'll see what the randomized data show. But I think ADCs and the bispecifics for small cell lung cancer showed, I think some very promising results. We even saw some CAR T data, CAR T therapy for small cell lung cancer. So I think there's a lot of investment and interest in research for small cell, and I think the outcomes are going to continue to get better there.
On a different note, another study that I saw that I really appreciated was there was a patient meta-analysis that was done evaluating patients in randomized clinical trials who had undergone surgical resection of their lung cancer. And this took it basically a meta-analysis like this takes a look at all of the randomized clinical trials asking a certain question. And then instead of looking at each of their outcomes to try to answer a question, it starts over essentially collecting all of the data of all of the patients from all of those studies and puts them all together in a larger bucket to look and compare an outcome to try to address a challenging question. And in this situation, what was being looked at was for a patient undergoing a surgery for their lung cancer, whether a procedure called a VATS procedure, video-assisted thoracoscopic resection, basically a smaller surgery using smaller incisions, would be better, worse, or the same as what would be called a traditional open surgery, where there's a larger incision there. We know from studies in the past that the VATS types of procedures, the less invasive procedures, had quicker recovery. People had less pain. They had shorter hospital stays. It makes sense, right? There's less to recover from in terms of how much of the body has been traumatized as you're undergoing the recovery afterward. But what that analysis also showed was that for people who had a VATS procedure versus the open, there was also a 21% improvement in survival, 21% reduction in mortality by the type of surgery with that. There was no difference in how many people had their cancers come back. So it wasn't that one treated more lung cancer coming back, that a surgery was less effective. Now, that doesn't mean that nobody should have an open procedure, because technically there are times when a surgeon needs to do a larger incision to get something out, or if there's a complication, or for many other reasons. But for the most part, it really helps to cement what the movement has been globally about less and less invasive surgeries, and how that helps people recover better, get through their treatments better, and then survive better. So that was great kudos to bring back to our whole thoracic surgery team as well. They were delighted to see that. And all of that ongoing work to, again, be less invasive to a person. We talk about toxicity from treatment all the time. But surgery also is a big deal.
Yeah, I agree. I equally love that study. I love seeing that, a less invasive approach leads to better outcomes. That's always exactly what we want to see. Obviously, there's the appropriate person for a thoracotomy, which is like a big, huge incision on the side of the chest, couple inches at least, as opposed to a VATS, which is a video assisted thoracoscopy, where small little incisions about ½ inch are to an inch are put in, and sort of trocars with cameras are put in there, and the surgeons are able to look through the cameras to cut the mass out and do what they need to do and remove it that way through one of the ports, as opposed to making a big incision. So making those smaller incisions and using cameras ended up having a better outcome. I'm also wondering, did they have a better outcome because they were able to recover faster and get whatever subsequent treatments that they needed after faster, as opposed to a thoracotomy that needed more time to heal? And I don't think I really got a good sense of that aspect of it. Did you? Did I miss that?
That wasn't specifically analyzed or called out, but that was offered as a big part of all of it, is that there were fewer complications after surgery because people were able to be recovering faster, breathing better, moving more, but also people were able to get to the next steps in their treatment and get through that. That was the assumption and implication with it, although they didn't do a direct analysis of that part.
Exactly. Anything else from you, Stephen? I know we have about 7 minutes left here.
I think there was a lot. We saw a little bit of data from KRAS as well. So we've got some KRAS G12C inhibitors, sotorasib and adagrasib, that were currently approved for use after chemotherapy and immunotherapy. But in the laboratory, when we give these inhibitors with immunotherapy, they work so much better. There really is a synergy in promoting this immune response. It's just that when we do it in trials, the combinations were a little too toxic, that it wasn't safe. But with some of the newer drugs, for example, we saw data from a KRAS G12C inhibitor called olomorasib. When we gave that with chemotherapy and immunotherapy, the response rates were very high. The disease control rates were like 90%, and they seem to be very durable responses. And so I think that we're hoping to get closer to unlocking these durable immune responses to more of our patients, and this might be a strategy to do that for KRAS, which is an important subset of lung cancer. So I thought that data were exciting. We need to see randomized data, and we need to be convinced that this is a safe approach. And olomorasib is not the only drug that's being explored here. Divarasib, there are several G12C inhibitors that we think will be better. And so I'm excited about the prospects for better frontline treatments, and really trying to deliver immune benefits to more people.
Yes, definitely. The chat came alive in the last 5 minutes, as it always does. So I'm going to start with first thoughts from you both on alcohol and cancer, and how do you counsel your patients or advise your patients in this regard?
I think there are some associations between alcohol use and various types of cancer that do seem to be real, but I don't know that swearing off alcohol is necessarily something that I would encourage all patients to do. I would preach moderation, and it's something that I think is acceptable in moderate amounts, but it's certainly an area of study. And the reality is we don't really understand why a lot of these cancers happen yet, but it's something we're trying to figure out.
In terms of, I'll just take sort of that next step from there. Instead, I agree with Stephen on that. But in terms of alcohol on treatment, though, as well, again, it's really important we discuss being very cautious about alcohol, and being using alcohol in moderation or to minimize it when a person's on chemotherapy, or particularly when a person's on a targeted therapy in which we're needing to carefully monitor for liver toxicity. And so there are different aspects of that we really have to take seriously, and try to help reduce the overall toxicity to the body. There is still a tremendous amount that we have to learn about the risk of developing a cancer in the first place directly from alcohol versus other things, but we do have evidence out there that shows that there is some risk, in that there isn't any study to say this amount is safe. So that has to also be in there too. It doesn't mean that every amount is absolutely unsafe, but how do you quantify those things? It's something we don't have the numbers for you.
Yeah, I think it's tough because we've seen patients have elevations in liver enzymes while they're on therapy. And did that come from the Tylenol that they used over the weekend? Is it from their statin medication for their cholesterol? Is it from some supplements that they might be taking that they're actually having better quality of life on and want to continue, and understandably so? Or is it from the alcohol that they had? Who knows? And I think it's difficult to say. I think you always want to try to eliminate things that could potentially complicate things for patients. But Stephen, I hear you too, that like, I always say like in moderation, right? So, on a holiday, on a special event, I think it's okay, but it's difficult to say, and I don't think we really know the right answer there. There was some data presented on ALK, and I see that mentioned here in the chat. Some like a spinoff of the ALINA trial that looked at patients that had resected lung cancer and then went on to receive adjuvant or alectinib post their surgery. And then there was a study that was done that used crizotinib versus observation in this space. Wasn't very excited about the data. Was it any comment from either of you or anything else that you thought was exciting in this space?
So this was the ECOG 4512 study looking at, after surgery, crizotinib versus observation. And this was a negative study, really showing giving crizotinib in the setting did not achieve the types of results that we saw with ALINA. It doesn't negate the ALINA approach at all. I think that giving targeted therapy after surgery for ALK-positive lung cancer should still be considered the standard of care. It's just that the drug matters. And crizotinib, while it was our first ALK inhibitor, it is currently just not, I think, a relevant drug. I think it's just not good enough.
I think it really highlights the importance. Now, granted that the study was activated way before the ALINA data, way before the alectinib data, that had been a very long time in coming, but it really does highlight the importance of picking the right drug for the situation, the most effective drug in a situation. And it also says that we can't just blindly apply any TKI in any situation and assume that it's going to have the same outcomes. And so making leaps to think about other sensitizing or other actionable alterations and saying, well, of course, if we add those targeted therapies before or after, we are going to have the same outcomes that we've seen, for example, with NeoAdora or with Adora. We don't know that part. And this is where those humbling results come in to say, we really do need to understand that before we just make presumptions.
Yes, and we are just at time. So I thank you for this discussion. I learned so much today. I've taken pearls from both of you. Do you have any last one-liner for our folks before we all log off and say goodnight?
Well, I do think we'll see a lot more data from ESMO as well, and so some interesting studies. So I look forward to hearing you discuss those things as well, Liz.
I think I would echo that and just say the pace of the advancements is only increasing. We have just seen this tremendous trajectory of strides that we have been making, and that's going to continue. It's a very exciting time.
Thank you. And thank you all. If there's any remaining questions, you can always send them out to the administrators, and we're happy to entertain them. But it was great. Thank you all. Big crowd, great questions, good topics. I hope you have a wonderful night. Take care. Bye.
Thank you. Take care.